everybody. This is Dr. Ben Pearl, and we're doing another episode of Fit Foot You with a colleague of mine that hails from my alma mater state, Indiana, Patrick Deheer, Dr. Patrick Deheer. He's a residency director, and I'm going to let him tell us the name of the program that he's at. But he's been practicing in a group and is on the board of trustees at APMA. Welcome, Patrick, and we've got a lot to review today with evolving surgical trends and your experience as a residency director. Tell me a little bit about your hospital and the residency program that you're the chief of now.
Sure. Thanks, Ben, for having me. It's great to be on. I'm the residency director at Ascension St. Vincent's, Indianapolis. We have 12 residents, so it's 4 residents per year. So it's a pretty big program. I took over as residency director about 5.5 years ago. I've worked with residents my entire career as an attending surgeon. Oftentimes residents would get a lot of their rear foot cases with me over the years. So I've trained a lot of surgeons over the years, but the opportunity came up to take over as program director, and I had to really think about if it was something I could fit into my schedule. And I've always loved teaching. So once I figured out how I could make it work from a time standpoint, I accepted the position, and I've really enjoyed being residency director. And also we have an externship program in our residency. So we have 4 to 6 students from all the schools that rotate each month. And all the students spend a full week with me while they're here for the month. And so I'll usually have 1 or 2 students with me that are following me around in my office and in surgeries also.
We were talking in our pre-interview about some of the interesting things you're doing with the flat foot, the pediatric flat foot. Obviously, you had told me about how things used to be and how things are evolving. Maybe you can encapsulate some of those experiences you've had both as an attending and with your residency training that you do.
Sure. Pediatrics is something I've always enjoyed in the subspecialty within podiatry. That's one of the reasons I love podiatry so much, is because you can kind of craft whatever career you want within the profession with all the multiple subspecialties. And I've always really enjoyed pediatrics, even from when I was in training at Winona Memorial Hospital in Indianapolis. My mentor, Rick Lundeen, did a fair amount of pediatric surgery, and then I got involved in international medicine and going to different countries and doing clubfoot. So I started to visit Ignacio Poncetti at the University of Iowa and learning his technique from him directly. I went out there several times and received training from him, and working with some other pediatric orthopedic surgeons over the years and in countries that I went to, like Kay Wilkins, who was a renowned pediatric orthopedic surgeon from the University of Texas, San Antonio, and Harold Van Balsey, who's been at Shriners now. I think he's left there. But so I've had experience with these people over the years, and it's really helped shape my love of pediatric foot and ankle. And because of that, I have developed a decent sized patient base. It's interesting, a lot of podiatrists, I think, are intimidated by the pediatric patient and don't want to deal with them for various reasons. But I do get a lot of referrals from all over the state for kids, and it's become not my entire practice, but it's definitely a substantial part of it. And the pediatric flat foot is a really interesting topic, I think. And when is it treated conservatively? When does it become a surgical problem? When does it need treatment at all? And what's the appropriate time to start treatment? Those are all really interesting topics that are part of the bigger discussion of this deformity.
What in your experience has been some of the things that fall into the clinic that you see maybe later in the game that you wish would have been addressed earlier? Give me some of the typical scenarios that come both with either the pediatric flat foot or club foot. And I realize those are 2 different kettle of fish, but you probably have some thoughts.
Sure. The pediatric flat foot's interesting because I think pediatric orthopedic surgeons tend to be a little more conservative because they only see those feet until about age 18 or so. Whereas podiatrists, we see those feet all the way up to 80-year-olds and 90-year-olds. And we know what that kid with a flat foot at age 10 is going to be like when they're 60 or 70 years old, because we see those same patients, whereas a pediatric orthopedic surgeon doesn't necessarily follow the foot through a lifetime. So I think, I might be a little more aggressive in treatment, not necessarily surgical, but just even with orthotics in treating it. And I think it's really important. One of the things I try to really stress to my residents, a lot of students who are, as they're going through the residency selection process, migrate towards our program because of the pediatric component of that a lot of programs don't have. But I try to stress to them that, the arch in a kid doesn't really start to develop until age 4. So when you have a toddler, it's the 3 F's is what I call it. Their feet are flat, floppy, and flexible. And that's the way they're supposed to be. So around age 4, we start to see architectural development of the arch. And that continues through age 9 or 10. So it's really imperative, I think, in most cases. Now, there are obviously exceptions, and this is for non-rigid flat feet, so not tarsal coalitions. That's a whole other discussion. But really letting the arch to develop to see where it's going to land around 9 or 10 to then determine, okay, do we need to do anything with this? Now, if it's significantly abnormal for the age, and there's been some work that has been done in the pediatric orthopedic world that has sort of standard radiologic measements for key things like Meary's angle and calcaneal inclination angle per age and where those things should be. But if it's severely abnormal, I don't have a problem with treating like a 5 or 6-year-old with some orthotics and stretching if they have a equinus component to it also. But I don't like to do anything surgically until they've at least reached 9 or 10 years of age. I do think if you're going to treat a pediatric flat foot conservatively, that oftentimes they do have an associated equinus. And one of the things I've kind of learned through the School of Hard Knocks over the years is dealing with the equinus is really important first. I think it's 2 steps, and I always tell the patient's parents this. You have to stretch them first and then go into the orthotic second. One of the things with equinus is the compensation for equinus that it happens within the foot. There's proximal and distal compensation. The distal compensation is essentially the navicular cuneiform joint flexes to make up for lack of ankle joint dorsiflexion through the mid stance or the second rocker gait. And if you have a well-made orthotic with a nice high medial flange and a deep heel cup pushing up on that medial side of the foot, and the calf is trying to drive the arch down to compensate for equinus, they just don't get along very well. And you get this kind of war between the orthotic and the calf muscle, with the foot's the battleground. So the kid will come in and not wearing the orthotics. They won't wear the orthotics because they're hurting their foot, and the parents are frustrated, and then they're mad at the kid, and then they're frustrated with you. And so I started to realize this several years ago that, I knew what was happening, but I started to develop this protocol in my own head where I was like, well, I need to stretch them first to remove this deforming force of the leg onto the foot, so the foot can accept the control that it really needs to adequately be doing something for them and supporting their arch enough externally. So I use a brace that stretches them, and I have them wear it for 3 months and adjust it monthly. And so in about the 3rd month of treatment is when I'll take impressions for orthotics, send those off to the lab to have them being made while they're in that 3rd month. And so once they're coming out of their static stretching program, then the orthotics are right there and they're ready to go into them. And I see much better orthotic compliance when I do that sort of approach with the non-surgical treatment for kids.
Now, before we get to any specific procedures, do you have in your head sequela of the flat foot that you're looking for? Things happening higher than the foot and ankle, or the foot itself, that give you a sense that this is going to require something more aggressive in terms of treatment?
Yeah, that's definitely a controversial topic, and you'll hear, pain is one thing, but oftentimes kids don't relate pain to their feet. But I think there are multiple components to making that decision, and symptoms are certainly one thing, but another thing are functional limitations. And I'll talk to the parents about this. Does the child participate in sports? Do they keep up when they're out walking together or shopping or whatever? Are they always wanting to sit down? Those are kind of functional limitations. And then I also think severity of deformity matters too. Like, I'm a big person for hindfoot alignment views, and then AP and lateral weight bearing foot x-rays, and ankle. You need to do an ankle AP. That's really has evolved from the progressive collapsing foot deformity series of white papers that were published in Foot and Ankle International in 2020. So those are actually considered mandatory x-rays in a flat foot case, whether it's an adult or a child. So looking at all those radiographic parameters, but I also think a biomechanical exam is really important to determine the severity. Now, there's a little bit of subjectivity in what I may say is a more severe deformity to what you may say is a moderate type of deformity. But clearly on x-rays, there are some parameters that have been established, but you really need a 360-degree look at it. That's why all those different films are important in evaluating the child's foot alignment. But if I have somebody that meets one of those criteria, then I'm probably going to transition them more to a surgical approach, particularly if they've had orthotics already. I don't necessarily think that a kid has to have orthotics before they go into become a surgical candidate if they meet any of those criteria, and particularly if they have what I would consider a severe deformity based on clinical findings and radiologic findings. And then if you add symptomatology into it too, then that can, shift the focus to more of a surgical approach. I understand being conservative with children, and but the fact of the matter is orthotics don't change the arch structure. So another consideration is if you have a 12-year-old female patient with a flat foot, as she gets older and into her late teens, her shoe gear preferences are going to become more challenging, and her ability to use orthotics and to be compliant with using orthotics is probably going to diminish as she gets a little bit older. Not in all cases, but in a lot of cases, even for boys too, and male patients, but female patients especially. And then are they going to wear those through adulthood? So those things are all part of that decision-making process. And when I have honest conversations with the parents and try to say, well, I don't see this as the long-term solution. This may be more of a surgical better way to change the architecture of the foot and give them an arch that's going to actually hold up for a lifetime.
Well, I'm glad you brought up function. I have some colleagues that have talked about in the sports medicine world of going to the halls of these Olympic marathon museums where they have bronzed casts of past champions' feet, and they'll talk about the quote unquote fit flat foot. Mm-hmm. So at least in the minimalist world, there's a lot of controversy regarding, well, is a flat foot a problem functionally if you have these guys running winning marathon times? Mm-hmm. That said, we certainly don't know, later on in life and what their other functions are, other than the fact that they were certainly able to navigate. And a lot of that has to do with probably just the physiologic development and their training, and, going back to that as well. Any other things that you would want to add as a caveat to that thought with athletes with quote unquote fit flat feet?
Absolutely. I mean, I was the team podiatrist for the Indiana Pacers for 30 years. So I have seen a lot of professional athletes over my career. And, it's unusual with professional athletes to see a normal arch structure in my experience with NBA players, but because of my role with the Pacers, I would see other athletes as well. And oftentimes you see a lot of really bad flat feet as part of it, or sometimes cavus foot structures. I rarely seem like I would see a relatively normal arch structure. And that foot function may not be a problem at that moment in time, but we know as people that see these patients over a lifetime that ultimately it will lead to a problem. Like if it's Shaq who ended up with severe hallux rigidus because of improper mechanics, one of the questions, because I'm a big Aquinas person, I've lectured a lot on it, and that I work with professional athletes, I would get sometimes when I lecture is, well, let's say you have an NBA basketball player that has Aquinas but no symptoms. Would you treat their Aquinas? And they're trying to kind of be controversial with me, like asking me if I would do surgery on their Aquinas, and that's not a very good question. Of course, I wouldn't do surgery on them, but treating them with static stretching to treat the Aquinas, which is a pathological process, it just hasn't evolved into a symptomatic pathology. Absolutely, because if you think about running-based sports, the three most common injuries in running-based sports are plantar fasciitis, Achilles tendinopathies, and medial tibial stress syndrome. And all three of those things, either the number one risk factor or one of the top risk factors is Aquinas. And I put forth that, like many Achilles tendon ruptures, the Achilles tendon doesn't rupture when it's a normal tendon. It's a diseased tendon that ruptures. And like I put forth that, like Kobe Bryant, for example, if he would have been stretched his whole career, you could have probably prevented him from rupturing his Achilles tendon, because there was a pathological process that led to that rupture. It just didn't happen all of a sudden. There was a stepwise process that led to it that could have potentially been prevented. So I think there's an opportunity to prevent a lot of these injuries in athletes, and the same thing applies here. And like you're talking about these runners or whoever have these awful flat feet. And yeah, they may be fine when they're in their 20s, but what are they going to be like when they're in their 30s? And like, the hallux rigidus really ended Shaq's career, and other players too have had problems that, that have transitioned. Some of the players that I saw for the Pacers, one of the players in particular had a really bad cavus foot, and that sort of ended up taking his career out. So I think if we can be preemptive in the treatment with some really good biomechanical care and physical therapy type stuff, then we can prolong their care and reduce risk of injury.
I want to jump back to the surgical discussion a minute, because in the 90s, it was very popular to do arthroresis procedures, kind of developing from the research done in the mid 80s with the literally fashioned implants that would be done on the surgical table, to matching them up to more evolved systems like the MBA system. And just for the lay folks out there, we know that these mainly affect the frontal plane. I want to know from your experience, though, in folks that may still favor that procedure, and we talked about some things that limit billing and research studies that have sometimes insurance companies have not seen enough evidence that they want to mandate that they are going to cover for that procedure. But all that aside, do you still see instances where you think that that can be used successfully in a frontal plane deformity, or what else are you thinking that needs to be added to the mix?
Well, I'm a big principles person, so principles are truths, and if you accomplish principles, then you should have consistency in your outcomes. So for me, whether it's a cavus foot or a flat foot, and that means if it's a kid or an adult, doesn't matter. When I want to remove any deforming force of the leg onto the foot, number one. Number two, I want to get the heel vertical to the ground. And number three, I want the forefoot parallel to the rear foot. And there are different ways to accomplish those in the pediatric flat foot. So the first thing is dealing with the Aquinas. So I almost always do a Baumann procedure when I'm treating a pediatric flat foot. It's extremely rare for me not to. The contracture is in the muscle the majority of the time when there's Aquinas. And that's the level that you work at with a Baumann. It's intramuscular fascial lengthening of the gastroc. So you're kind of working at the quote unquote quora of the deformity there. It's like in kids with CP, it's by far the preferred method. There's one sort of different group of kids that it's not in the contracture's not in the muscle, it's in the tendon. That's in idiopathic toe walkers. There's been some research that showed that actually they do have a shorter tendon. I'm not a fan of TALs. There's a lot of risk with TALs that are unnecessary. So in that patient population, I'll do a Strayer instead of a Baumann, but the majority of the time I'm doing Baumanns. And the next thing is, well, how do we going to get the heel vertical to the ground? And there's a lot of research in surgery that shows that's the ideal position. And particularly with a hindfoot alignment view, where we're looking at the bisection of the tibia and the low point of the heel, that really should be vertical. Saltzman and El-Khoury wrote that first article in 1995, and they actually showed a slight inverted position of the heel relative to the tibia. But with weight-bearing CTs that have become more popular, they went back and they compared the hindfoot alignment view and weight-bearing CT hindfoot alignment, and they showed that the hindfoot alignment view overestimated the varus position a little bit, to the point where really the ideal position is vertical. So there's plenty of research on that. So the options in a pediatric patient are a subtalar arthroresis or an Evans procedure, in my opinion. I used to do a lot of subtalar arthroresis. Rick Lundin was my mentor. He actually modified the Smith stay peg and had his own version of it. And we did a lot of those when I was in residency and fellowship with him, and then early in my career. But then insurance has stopped covering them, and so it became difficult to utilize them. And I kind of switched over to the Evans. And I think the Evans is an extremely powerful procedure. It's one of my favorite procedures to do. One of my very favorite articles, and I'm a total article nerd when I lecture, it's very much article based, is this finite element modeling where they had a flat foot, a normal foot, a flat foot, and then a post Evans foot. And they looked at like muscle function, and they showed like with the pronator longus, which is an incredibly important muscle function, in a normal foot, and then a flat foot, it's like 76 Newton meters. And it goes down to almost like 0.6 in a flat foot. But when you do an Evans, it goes over like 47. So it's almost more than halfway. And then they look at like pressure distribution, particularly in the first metatarsal head, and then the pressure on the ligaments and the medial column joints, like the first metcuneiform, the NC joint and the TN joint, and how it goes up like 40 times when you go from a normal foot to a flat foot. But then when you do an Evans, it actually takes it back down. It doesn't fully correct all those things because there are multiple components. You have to deal with the medial column too, not just the hind foot. But an Evans is an incredibly powerful procedure. And one of the things that I find interesting when I lecture sometimes on pediatric flat foot, people will say, well, I don't do a posterior muscle lengthening until after I do the Evans to see if the muscle's tight. And that's actually the absolute wrong way to approach it, because when you do an Evans, it does correct in the transverse plane, but it's a triplanar correction. It also plantar flexes the forefoot relative to the hindfoot. So that plantar flexion of the forefoot relative to the hindfoot increases the calcaneal inclination angle. The only way that that can increase the calcaneal inclination angle is if the Achilles tendon isn't pulling the back of the calf or the heel up. So you have to do a posterior muscle lengthening first to maximize your Evans correction. To do it the other way around is you're really selling your Evans short. And so I do Evans probably 95% of the time. Then on the midfoot, oftentimes I'm doing a cotton procedure because there is a forefoot supinatus deformity, particularly once a kid's kind of getting past that 10-year mark, their foot's adapted to that position. And a big fan of the cotton. The thing about cottons is that you really need to use as big a wedge as possible. Right now, whether you use PEEK, metal, or bone, they only go up to size 8s. Industry's coming out with size 10s, but there's research that shows the correction of a cotton is directly related to the size of the graft. And if you undersize it, you're undercorrecting the forefoot varus. And there's a sort of an old saying in any type of orthopedic surgery, thou shalt not varus. When you're fixing a flat foot, you cannot leave any varus because the compensation will wreck your hindfoot correction if you do. Or like if you use a subtalar arthroresis, and this is something I would see a lot when I would fix kids that had had surgery before with just like a subtalar arthroresis, but nothing was done to the medial column, it causes jamming of the subtalar joint where the subtalar arthroresis is. And it's not because of the implant, it's because there's an undertreated forefoot pathology there. So, a cotton's a big component of my treatment too. And those things all sort of work together. I mentioned to you when we talked previously that every once in a while, and this is really rare, maybe I'll see it once every couple of years, about the maximum Evans you can put in is a size 10. So I mostly use size 8 or 10 grafts. If you go over a 10, which they do have size 12 grafts, it's been shown to increase the pressure in the calcaneal cuboid joint above a threshold that is consistent to preventing arthritis in the joint. So I don't go above a size 10. So you're kind of limited there. And the cottons only go up to 8. So you're maxed out on that. And I'll have a kid every once in a while where I put in like a 10 Evans and an 8 cotton and do a Bauman, and everything looks good initially, but down the line, they start developing this sort of peritalar instability is the best way I can describe it. And that terminology has been embraced by the progressive collapsing foot deformity literature that's come out. And that's actually one of the categories, that's category D of the new classification for PCFD. And then what I have found is when I see that, I'll take those kids back and I'll do a subtalar arthroresis on them, and their foot is perfect. It like just turns out perfect, but it becomes a little bit of a complicated situation because you do the surgery and then the arch is still flattening. The parents are like, what's going on here? And sometimes they can lose trust in the process and and they don't want you to do it. They don't want their kid to have to go through another procedure, even though it's a really minor procedure. But the one thing that's been sort of gnawing at me is I haven't been able to identify those kids ahead of time where that's going to happen. I wish I could, so I could, now I kind of tell all parents when we're talking about a flat foot surgery that there is a chance that I use the word fine tune. We may have to fine tune the procedure with a small secondary procedure. I tell everybody that now ahead of time because I've learned through, where I didn't tell them before and the frustration and, people being upset with the outcome and then not allowing you to make that next step that is really needed to really dial in the position of the foot. But I personally don't think you can do an Evans and subtalar arthroresis at the same time because the implant sits right above where the Evans wedge is, and I'm afraid it would dislodge the wedge and complicate that. So I wish I could identify them ahead of time. I can't, but now I just tell all the parents that. And it's really rare, but it happens. But when it does happen, it's a very frustrating thing. But there is an easy solution, in my opinion.
I'm glad you mentioned the sequencing, and it's really showing in this interview how you've kind of dialed in with the experiences that you had to make it more acceptable and palatable for the patient's parents so that they have a clear blueprint of what's going to happen next. Sometimes we run into situations where none of us know what's going to happen next. We've all had our complications.
Right.
You had a humdinger you talked to me about in the pre-interview, and they happen to all of us. And you do a lot of reconstruction. And, what was that old expression? If you cut, you cry sometimes. So tell us about, either that case or some prolific case that you think was interesting that, despite best efforts, you still had some things to try to bail out and get an outcome that you could live with.
Yeah, I think that was the clubfoot case from Haiti I was talking to you about before. And that changed my approach to clubfoot pretty substantially. I went to Honduras 3 times. That was sort of I've been on over 30 international trips. And the first 3 trips I went to were Honduras, and I wanted to go somewhere else. So I went to Haiti, and I had a small group of people with me, and was operating in a hospital outside of Port-au-Prince. But then a small subgroup of us went into the country, and I met this 8 or 9-year-old boy who had bilateral clubfoot that had been neglected, never treated, and it was getting more challenging for him to walk. And his parents decided to have surgery, so we brought him back to where we were operating. And initially, he was kind of a tweener, like soft tissue release versus bony. So I tried doing a posterior medial release and a tendo Achilles lengthening, and it just wasn't correcting the way I wanted. So intraoperatively, I decided to do a talectomy and then a lateral column shortening procedure and pinned it. And his foot position was good. And so I did a bunch of surgeries that week, and I went home. And later the next week, I called the orthopedic surgeon who was sort of coordinating everything and asked him how everybody was doing. It was like, everybody's doing great except for that kid you did the clubfoot on. We're going to have to amputate his leg. And I was like, well, wait a minute, what's happening? And he said that medial incision where we did the posterior medial release had dehisced, and it was down to bone. It wasn't necessarily infected, but it was a pretty aggressive wound, and they didn't think they could deal with it there. And I said, well, just, how much time do I have? And he said, I can maybe deal with it for about 2 weeks before we have to do something more definitive. And I said, well, don't do anything, just do standard wound care. Let me see what I can do. And I have fair amount of connections. So one of our state senators, 2 of his sons were in my fraternity at IU, and I worked through him to get this young man. He had no documentation. He got a visa and a passport, and he lived in the middle of Haiti with nowhere. And there happened to be a group from Indianapolis and Port-au-Prince. So we got all of his paperwork lined up. There was a group down there from Indianapolis. they were able to bring him home with them on the flight. The hospital I worked at the time agreed to take care of him for free. I got a pediatrician, infectious disease doctor, and a plastic surgeon involved, and we got him stable medically. And then we planned this sort of big procedure where I was going to fix his other foot, and we had to do it in the evening after all the standard surgeries were completed, the sort of normal procedures, because everybody was doing it for free, including anesthesia. But I did his other foot. I just did the talectomy, lateral column shortening procedure, and did all that. And then the plastic surgeon, two plastic surgeons came in. They did a free rectus abdominis flap and hooked that up to his posterior tibial artery, and then they did a skin graft over that. And all that ended up healing. He was in the hospital for about 2 months total, and then he stayed after for kind of observation and full rehab for about 4 months or so. So he was here for about 6 months, and he went to school and became kind of a little rock star. There were some articles written about him and his journey, and there was a news station thing, but that was on TV. But the whole thing about that experience for me was like, there has to be a better way. And that was kind of, the Ponseti method was becoming more accepted at that point in time when this happened. So that's what drove me to start going to the University of Iowa to spend time with Dr. Ponseti, because I realized that, clubfoot surgery is a really risky procedure. And if you do it, you're going to have serious complications that lead to even amputation. And in a kid, that's a devastating thing to kind of deal with for, personally as the surgeon, but obviously for the patient too. But I've seen it. And, I was like, there has to be a better way. And that's, I got very involved with Dr. Ponseti at that point.
Now, was this also the case where there was some torque on some of the fixation, or was that another?
No, that
was another case. That was
Yeah.
another case. So let's go now from, we've talked to some really complicated reconstructive type cases to more mundane and sort of everyday pediatrics. We all see Sever's disease in our practice, and for the lay persons that don't know what Sever's disease, it's a growth plate abnormality that occurs in the back heel growth plate area. We see it a lot in kids that play a lot of activity, soccer and multiple sports, etc. Are there any things that you have learned that have helped you with some of these growth plate anomalies, other than waiting them out? Obviously stretching, and you have a nice equinus splint that you've developed. Share some other things that you think might be some good tips with growth plate anomalies.
Well, I think the biggest thing with Sever's is there's actually some really good literature that it affects these kids' quality of life. Because if you think about being a 10-year-old boy, for example, and you're in a sport, let's say you're a basketball player, and you can't play basketball because your foot hurts. That's like the number one thing, the most important thing in your life at that point in your life. And if you can't do it, that's definitely going to,
especially if you're in Indiana, right?
Right. That's why I use basketball, because we're in Indiana. But it definitely affects our quality of life. So there is robust literature that we need to be treating this, and we need to be treating it comprehensively. And Sever's is something that is, I think, pretty straightforward from a treatment standpoint. But one of the big pieces of literature is that almost 100% of these kids that have Sever's have equinus. And if you think about Sever's, it's a traction apophysitis, and there's really well-established literature that the tibia and fibula grow faster than the gastroaxilleal complex. So oftentimes we think of these kids as really active, but they're also often going through growth spurts. So as the tibia and fibula are growing, the calf muscle then gets put into this temporary equinus deformity that then causes traction on the calcaneal physis, and that leads to a lot of this. Now the activity and stuff compounds it, but so I think stretching is really important. I think you have to reduce the inflammation. I'm aggressive. I use oral steroids a lot, and they work great and they work fast. And they really have very little risk. And then I think you have to reduce shock. I like a Thule heel cup, like a soft rubber waffle cone type design. And if that's not enough, I'll use an orthotic. I really try not to have to limit kids' activities unless they're not responding to that type of sort of standard therapy. If they are, then I'll start to ratchet down their activities and immobilize them more. It is a self-limiting process, as we all know, but the key, though, is if possible, allowing these kids to continue doing the activities they want. And Jim Amos, who's a retired foot and ankle orthopedic surgeon from Cincinnati, he was the team orthopedic surgeon for the Bengals for a long time. He has written a lot about equinus, and we've talked a lot about it with each other. We have this shared interest, and he thinks that people who are tall, I'm 6'5", like myself, because they're always going through growth spurts, are in this perpetual state of equinus. And like with me working with NBA players, just anecdotally, I can tell you, like, all those guys had terrible equinus because, I think that's a big part of it. Their foot structure is part of it too, but all of them being tall, I think that's also a component of what Jim was talking about in his theories about the growth spurts and being in a perpetual state of a growth spurt.
Just to clarify, in youngsters at the Seaver's age, you will use low doses of prednisone?
Yep, I do a med roll dose pack, like no problem at all. I mean, if those kids get poison ivy or if they get a bee sting and are allergic to it, they'll go to the ER and they get put on a med roll dose pack all the time. It is not a big deal.
Okay.
The pills are
All
really
right.
small too because it's easy for them to swallow too. They're not like big giant pills.
Sure. Let's move on to something that's very popular and trending in the cyberspace. That is the idea of Lipoplasty. And for those that don't know, I just want to, for our lay people out there that might be watching this, that's going to occur more proximal back here as opposed to a head osteotomy. And the whole principle, as you can explain, is to try to stabilize the medial cuneiform area. It involves a little bit more hardware, and it's approached with a lot of heavy marketing. So let's have your unadulterated thoughts on Lipoplasty.
You're gonna get me in trouble here.
You gotta walk the tightrope, but you also got to say what you think.
Sure. Well, our understanding of bunions has changed a lot over the last 8 years or so. We, used to think of bunions as a two-dimensional problem, but we've come to understand that it's a three-dimensional problem. And really, there are 140 or so different bunion surgeries or variations of surgeries described in the literature. When you take that triplanar component of bunions into consideration, it really reduces the options to like 3 or 4 that make sense, that really correct in all 3 planes. One of those is a straight like Homan type osteotomy at the head, which is like a Siri procedure. I do that MIS, and I think it's a great option for like mild to moderate bunions. Another one is a Lapidus procedure, which allows for triplanar correction, and that's where a lot of the sort of revitalization of the Lapidus procedure via the Lipoplasty technique has evolved over the last 6 years or 7 years. And then the other procedure I do a ton for hallux valgus is first MPJ arthrodesis. That's actually one of my very favorite surgeries to do. I would argue I may do more than anybody in the country of that particular procedure, but Lipoplasty, I'm not a fan of. I don't like the direct-to-consumer marketing on it. The Lipoplasty is a Lapidus, and it's just how you want to do it. I don't need a clamp to rotate the metatarsal. One of the things I have a problem with most of the systems that use cut guides is they take out too much bone and they shorten the first ray too much. And I've done a lot of research because I have lectures on this topic. You can really shorten the first ray about 6 millimeters before you start to get in trouble and cause lesser metatarsalgia and sort of medial column insufficiency as well. And that's if you don't dorsiflex it. And it's funny when people post their Lipoplasty pictures on social media and the first metatarsal is nice and straight and the toe looks pretty straight. And I look at how short it is, first of all, and it makes me cringe. And I'm just like, oh, this patient's going to have problems coming down the line. But the other thing is they never show their lateral. So number one, how short is it? Number two, show me your lateral. They never show the laterals because there's always metatarsus primus elevatus. I think a Lapidus is actually a very difficult procedure. Now, having a clamp and this other stuff to try to make it a little more predictable is, Maybe it's because I've done it before that and I don't need it, but I've never been a fan. And the first thing that I didn't like about Lapoplasty was the shortening. And then also, I just didn't think the fixation was robust enough. And they have actually changed their fixation from the beginning quite a bit over the last few years. It's evolved. And I think because there's been failures with the less than robust fixation, I find it interesting that for most things, we want primary bone healing, but for Lapidus, they're saying, well, you can do secondary bone healing, and I just don't understand that. I think that their fixation changes over the years would indicate that initially it was failures associated with that. The other thing too is when this whole thing came about with the increase in utilization of the Lapidus procedure, it was like, you don't have to do anything at the MPJ. You just have to get the metatarsal straight and don't worry about anything at the MPJ. Well, you do. Clearly, a lateral release is related to recurrence rate. And when you don't do a lateral release, you have a higher recurrence rate. And I think there's other things too that lead to recurrence, but that is one of the major things. So now you see even some of the literature that's come out with Lapoplasty, where they were saying initially you don't have to do lateral release. Now almost 100% of the time they're recommending a lateral release. And why did they change? They changed because they were seeing recurrence with it and they wanted to change the outcomes. One of my big problems is like a lot of the physicians who I like a lot and know and respect, they published some research recently that showed a 0.6 recurrence rate with Lapidus procedure. And that's statistically impossible. I think there's a 117 patient cohort and 116 of them did not have recurrence. Well, if you read the article, the way they define recurrence isn't standard in the literature, and the parameters that they used were utilized to stack the odds in their favor to get that 0.6. It's like they built the research project based on the outcome that they wanted instead of doing the research project and seeing what the outcome was. And the bigger issue to me is, though, they then advertise that to patients with direct consumer marketing, you have a 0.6% recurrence rate, and that's impossible. I've seen recurrence rate for Lapidus in literature all the way up to like 46%. So how can it be 0.6 to 46%? That's crazy. That difference is way too high. The best paper.
Well, I would even question too the chronology. How many decades are we even into the procedure being out there?
Right. The long-term follow-up. Yeah, absolutely. The best one that I've seen and that what makes the most sense to me is about a 15% recurrence rate. I think the lateral release is part of it. I also think there's a torsional component to bunions, and there's been a couple articles now that show there's a twist within the first metatarsal in patients who have bunions compared to patients who don't. And that's at the distal 1/3 proximal 2/3 junction, right where you do a distal procedure. And I don't care what you do at the back of the metatarsal. If there's a twist and deformity at the front, if you don't untwist it at the front, you're going to have recurrence. So that's what is kind of the leading to the distal metatarsal articular angle that orthopedics talks a lot about and is a big component of juvenile hallux valgus, a DMAA deformity, which is like what we would call a PASA in podiatry. It's real, and it's been associated with the recurrence, and it's very pronounced in juvenile hallux valgus too. So there, and like I said, it's not just one article. There's been more than one article that shows there's this torsional component.
Well, you superseded my expectations in the thoroughness and comprehensiveness of your answer. Let's talk, and we could do a whole hour on this, but let's just dovetail right into MIS surgery, and not only for the lay public that's potentially watching this, but also where this fits into modern residency training. I think that'd be a good place to talk about that as well. Some of the highlights and pitfalls, there's certainly been a lot more science that's been put into it, at least in what I've seen out there.
Sure. I mean, when I graduated in 1990, so I was at Scholl from 86 to 90. And around that, when I started, there was a big thing, I think it was on 60 Minutes, about surgery in Chicago, MIS surgery, and how terrible the outcomes were and how patients were maimed. And so I always had sort of a bad taste in my mouth for MIS surgery because that was kind of right when I was starting school. And then probably about, gosh, it's maybe 8 years ago or so, I was lecturing at a conference with Noman Siddiqui and Guido Laporta, and they were doing the Siri procedure back then, which was started in Europe, which is a Homan a minimal incision homing of the first metatarsal. It's a straight transverse cut, and it allows you to rotate in all three planes. And Bosch, who originally did the article, or Giannini, I think originally did it, would just use 1 2 millimeter Steinman pin along the medial side of the toe, and then it kind of hugged the metatarsal head. Then it was redirected inside the bone, and it created almost like a tension band fixation. And so actually those guys showed me that procedure, and I started doing quite a bit of them. And what I was seeing was a little shift of the dorsal distal fragment dorsally. So I added a second K wire from dorsal distal lateral of that metatarsal head to plantar proximal medial across the osteotomy. That first pin medially locks in the transverse plane and the frontal plane, but that second pin locks in the sagittal plane. And I found that, and the pins are about a 60-degree angle to each other, which is very X-fix kind of stability. And I found that works great. And so I've done probably a couple hundred of them now over the years, and it's a great procedure. The thing about minimal incision, it's been interesting to watch its evolution. I think if it makes the procedure easier and the healing better, and more importantly, the outcomes better, then it's worth doing. But like some of the procedures that are being done minimal incision really honestly don't make sense to me. Like, for example, people are doing first MPJ arthrodesis minimal incision. I just don't get it. To me, that's making a procedure that's very predictable. It's one of my favorite procedures. It is a great surgery. In fact, I call it the goat of all foot surgeries, the greatest of all time foot surgeries. And there's reasons for that. But you're making that procedure more difficult, and you're using substandard fixation, in my opinion, compared to what we have available now. I started doing first MPJ fusions, and right after I got a residency, because I saw how bad implants were and their outcomes, I was the only person in the state doing them. Everybody thought I was crazy doing them. All I had was like 3/0 cannulated screws. So I'd use 2 3/0 cannulated screws, or sometimes 3. And you'd have to have patients non-weight bearing. But the evolution of the fixation, now people can walk on it with a boot, protected, and it's a very, very predictable procedure. But to me, like doing a minimal incision is making it harder, and your fixation is not as good. So like I don't get it. I do a similar procedure for Taylor's bunions like I do on for regular bunions. I think with Charcot, there's some advantages to doing that MIS with X-Fix. But some procedures, I just don't get it. Like if it's making it harder and the outcomes less predictable, then I'm not going to do that. So I'm pretty selective where I use MIS, but I'm a believer in certain parts of it and not a believer in other parts of it. And teaching surgery to residents, including MIS, is a really interesting topic. I've worked with residents for 34 years, basically since I got out, and I've trained a lot of really talented people over the years. And those people who teach surgery, thank you for doing that, because not everybody will do that, and it's really critical to pay it forward, because people taught us how to do surgery, and it's incumbent upon us to teach the next generation and to give back. And I get frustrated when I hear about people that don't work with residents, and that just really, it's grating to me, and it's disappointing. But teaching in surgery is a stressful situation. It's your patient, the outcomes, you're held accountable to the outcome, but you're trying to let somebody else do it and teach them how to do it while that's happening. So it does take a certain proficiency in surgery, and you have to be comfortable. Like if I'm going to let you do a surgery, that if you mess something up, that I can fix it in the case, right? So you got to be able to feel comfortable with that. And not everybody does. And I get that part of it, but you have to be patient with the young learner. You have to walk them through it. I think there's sort of a sequencing of steps with each procedure. Like you do this part, then that part, and this part, and then you're able to do the whole procedure. If you just throw somebody into the fire, then they're going to drown, like it's too much too fast. And I think basic surgical skills are really important to teach, because if I'm doing a bunion, but I'm teaching you how to identify tissue planes and how to handle neurovascular structures and how to ligate vessels and how to dissect the periosteum and prep a joint, those things translate to like a subtalar fusion too, right? Like those basic surgical principles and skills. So you can teach those simultaneously, and it requires a lot of back and forth. It requires patience. It requires confidence that you can deal with something if something occurs. you also have to be able to read the resident. And if you can tell they're starting to struggle, you can either try to coach them through that struggle by giving them more directive with each individual step, or sometimes you have to take over. But if I mostly in our program, the third years work with me most of the time because most of the cases I'm doing are more complicated, more third year type procedures. And so they're pretty well prepared by the time to get with me. But if I have a third year that is really talented and they're progressing really fast, I may not, I'll just let them kind of go and watch them. I'm going to make sure they're doing it the way I want, but I want to see how far they can get before I have to intervene and say, no, 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 that's not how I do it. I want it done this way. And then, they'll do that. Now, some people, I've got to just each individual step. So you have to tailor your teaching to every resident because every resident is different.
Do you see a role for computer modular training and then tagging that also with AI in surgical training? And I guess we could also take that to trying to keep step with, spinal surgeons that are doing robotic surgery or gastric surgeries that do so where do you see some of the new technology tools? What is hype and what is more practical in your estimation?
It's interesting. I know for sure because I consult with a lot of companies that like weight-bearing CTs are becoming, we still don't have one in Indianapolis, which is the 13th or 14th largest city in the country. But if you have a patient with either a bunion or a flat foot or cavus foot, you get a weight-bearing CT, there's going to be computer programs that read those CT results and suggest procedures for you. Like you should do this, 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 and this. And it will show you what the alignment should be. Now, one of the companies I consult for, they're in the process of doing this. I don't agree with the parameters that they're establishing for the endpoint. Like I think that they're under correcting the deformity quite a bit, frankly. So, those things are going to have to be ironed out. And I think that, it's going to be an evolving process, but that's for sure happening. And that I think will help take out some of there's deciding the procedures can be challenging. Like when is it okay to do an Evans versus a subtalar arthrodesis for the hindfoot, or when do you need to do a cotton versus maybe a Lapidus and an NC fusion or a TN and an NC fusion. Those things, a lot of that's based on experience, but if we can, make that more accessible to people and more predictable through this, I think that will be better for patient outcomes. So that is for sure going to happen. I think I don't ever think robotics will get into foot surgery. I just can't see it. I think there's too much complications. When you're talking about teaching residents, the two things that they struggle with the most is seeing things in three-dimensional, but then also seeing like angles and an alignment. Like if I am trying to correct for something, I need to wedge it like this to get it over there, and then I need my fixation to be here, and seeing the whole big picture. But seeing things in 3D and then seeing the whole thing coming together is sort of the last steps in the evolution of learning from a surgical standpoint, particularly for rear foot surgery, but even for things like a Lapidus. Like I said, I think a Lapidus is very underappreciated how complicated that procedure is. So those things are great. I think, fixation will continue to evolve and improve. I think our biologics will continue to evolve and improve. I try to, when I'm doing these complex procedures, I try to stack the odds in my patient's favor. I'll throw everything to help them get the outcome that we both want. So if I use concentrated bone marrow aspirate to put stem cells in there, if I do vitamin D supplementation ahead of time, if I can get a bone stimulator from the get-go to make sure the fusions are going to heal, I'm going to stack the odds as much as I can to get the desired outcome that we can. Now, sometimes we're limited by insurance or facilities or whatever and what we can use, and that's a whole other discussion. But, there's always this, fight between what's going to be covered and not covered, and how can we get the outcomes that we need in dealing with all that.
Well, listen, you've hit all the bases. You've knocked it out of the park here this evening. Is there any general advice you would tell? And I had Mike Downey, and yours is really going to be a nice companion video podcast to listen to along with Dr. Downey's. And he was talking about making sure you absorb like a sponge every last nanosecond of that residency experience. Is there anything more specific that you would add in terms of making a more successful residency for those that are coming up in the profession?
Yeah, I tell, so it's mid-July and we just had our new intern starting, and I always tell the new residents when they're going through orientation, we have lunch together, then we go through my part of their orientation with them, and I usually tell them the same things. I say, number one, leave the residency program better than you found it. And I probably should say this to them also, but I tell this to other people all the time. Not only that, leave the profession better than you found it. Leave podiatry better than you found it. And that's one of the reasons I've been so involved as a trustee and teaching and all that stuff. So that's number one. So leave the program better than you found it. Number two is you have to maximize your educational experience. I think a lot of programs have a bit of autonomy to them, and you can, do surgery in the morning and then go home at noon and have the rest of the day off, or you can go to somebody's office and be in the office with them and learn how to evaluate patients, learn how to identify complications, learn how to treat complications, learn the decision-making process that goes into non-surgical treatment as well as surgical treatment, and when is it appropriate to order tests, when is it appropriate to refer, and those types of things you learn in the office. And that's one of the things I'm most proud about our residency program. It's very well rounded. So I know other programs don't have that office component. So you need to, if you can get into an office and spend time and really maximize it and read, you have to be a lifelong learner. You're going to learn the most during those 3 years of residency, but that's not it. You need to continue to read journals. I have a bunch of journals I go through every month, and I download articles and I either read them immediately or I put them in files for lectures I'm going to do or papers I'm going to write or research that I'm working on. I have probably about 4,000 articles on my computer right now, at least I would say. So you have to be a lifelong learner. And the other thing is you have to critically evaluate your outcomes. And that means surgically and non-surgically, your patient care. Like if you're doing something, it doesn't take me long to say, that's not working, I need to change something, whether it's in surgery or non-surgery. You have to always critically evaluate your outcomes and then make adjustments accordingly. And always put the patient first.
Well, listen, this has been quite informative. You exude a lot of energy. We all, as practitioners, have frustration with the insurance carriers, but I can tell that you're still energized, and I can tell that teaching and continuing to evolve is a passion for you. So thank you so much for doing this podcast. And Patrick, I like you even more. I didn't realize you were an IU grad.
Yeah, I'm a diehard IU fan, but I really appreciate being on here. It's been a fun conversation. Thanks for having me.
Okay. Peace and continued success to you.
Thank you so much.